Hi, good evening, everyone. Thank you for joining us today for our newest installment of the Getting Ready for the Maryland Primary Care Program series. On today's webinar, we're going to be talking to you about the CRISP reporting tools that are going to be coming up for everyone that will be a program participant starting in January. Just a quick few administrative items before we get started. If you have any questions, you can feel free to type them into the questions panel on the right-hand side of your screen. We will be taking all the questions at the end of the presentation. And if you've been following our webinar series so far, we're going to switch things around a little bit from the way we usually do them. We're going to kick off with just a couple of administrative updates first, and then we're going to turn the presentation over to our partners at CRISP so they can walk you through all the tools that they've been designing for the program. So to get started, we're going to go ahead and take a look at the timeline slide that at this point should be very familiar to everyone. But we did make a few recent updates here, so it's worth just going through this again. Right now, we are in the middle of November, so at this point, all of your onboarding forms that came out in October should have been turned in already. And we've also released the CTO arrangement document to the CTOs, so they can be working on their portion right now. In the next couple weeks is where we've actually shifted things back a little bit. The good news is that CMS is currently working through an attribution and vetting process. And so we expect them to make announcements about which practices have passed the next round of vetting in early December. What this means is that the letters for the CTOs that are going to list all the partner practices that have been partnered with that CTO are also not going to come out until early December. So what you can expect to see in the first week of December is CTO letters for CTOs. If you've partnered with a CTO, you're going to be receiving your side of the CTO arrangement. And you'll also have a package of materials from CMS that'll come out that same week. And one thing that hasn't changed on this timeline is the final date to turn everything in is still Friday, December 21st. So make sure you have that on your calendars and are ready to go with everything. Just a quick highlight on some of the more specific documents that you should be focused on for the next couple weeks. For the month of November, we have the CTO arrangement. So as I said, this has already been shared with the CTOs, and they are working on their half of the document. And for anyone who still needed to sign a participation agreement with CRISP, CRISP has reached out to those practices, so make sure that you get back to them and have everything turned in before things go live January 1st. In terms of the package of materials that's coming out in December, there's going to be the participation agreement with CMS. So each practice will be signing that document with CMS, and there's also going to be a data worksheet that is part of that document that you'll need to complete and sign and have turned in at the same time. Along with those, there's two portals that you'll be registering for. You'll be getting a link and instructions for how to sign up and register in December, but you're not going to get full access to those portals until everything kicks off in January. Once again, the deadline to note here is Friday, December 21st. CMS isn't going to push back this deadline at all, so please make sure that you're ready to turn everything in by that deadline. With that, I'm actually going to turn it over to my colleague, Chad Perman, who's going to talk us through the CTO arrangement and give you a little bit more on the vetting process that CMS is currently working on.
Thank you, Alice. Hi, everyone. This is Chad Perman. I just want to give you a quick update on a couple of items that we haven't talked about too much up until this point. So one of the documents that Alice talked about was the CTO arrangement. This is a document that solidifies the relationship between your partner CTO and your practice. For any practice that elects to work with the CTO, they will need to have an arrangement that confirms what those services are going to be, and clarifies all the expectations between the two parties. This is a short document. It is going to be 2 pages in terms of the main body of the document. It'll define and confirm the relationship based on the practice's option selection, that option 1 or option 2. It will be effective at the start of the program, January 1st. And to be effective, you also have to have a signed participation agreement. It will renew annually unless either party terminates it. It will identify the split of the care management fees based on that option selection. If you are choosing option 1 that requires a lead care manager from the CTO, it will outline that as well. It will have some language about data sharing between the practice and the CTO. And it will have language around termination and notification and timeliness for that. So that's the main part of the arrangement. Then there are 2 appendices. Appendix A is what the CTOs right now are filling out. We send it out to them so they can fill out in Appendix A the services and the staff that they are going to offer to their practices. So that needs to get filled out before the practice can see it and confirm it and execute it. What you'll do when you get it is Appendix A will be a fairly simple table, and it will outline by practice transformation requirement in the program what services and staff the CTO is planning on using and offering to the practice to help fulfill those requirements. The other piece of this is there's another appendix, and that's to confirm the data sharing relationship. So you will need to have a business associate agreement in place with the CTO in order to share clinical and quality and utilization data with them. And just to be clear, the practice here is the covered entity. The CTO is the business associate. To make this easier to get this back and forth completed, either party can originate the business associate agreement, but the practice needs to be identified as the covered entity and the CTO as the business associate. For the arrangement, as Alice had mentioned, the same deadline applies, no later than December 21st. We have it out to the CTO so they can have it ready as soon as the CTO letters go out and identify the practices that they are to send them to. And there will be 2 versions of the arrangement. One will be for the 50-50 option 1 split, and one will be for the 30-70 split. And the CTOs will know which option their practice has selected so they can send them the right template for this. You will need to execute it and send it back to the CTO as well as the program management office here at the department at our email address, mdh.pcmodel@maryland.gov. Just one more item here, and then I'm going to hand it over to CRISP. Just wanted to give you an update in terms of the practice vetting that's going on. As you know, your participation is contingent on the vetting and submission of documents. On the vetting piece, CMS continues to move through with its program integrity screening, which it does for all models. They're also checking attribution, making sure that practices have the 125 Medicare fee-for-service beneficiaries attributed to their practice. Other things they're looking at to make sure that the taxonomy for the practice is within an eligible primary care taxonomy that was listed in the request for application. So all of these are going on to make sure that the practice hits those requirements. That completion of the vetting is expected to be finished by the beginning of December. The other piece to be aware of that your participation is still contingent on is a submission of documents. So as we've hammered home and tried to work with all of you to make sure they get in, and I know you've probably worked closely with Alice on this, is that all the documents that you've sent so far on the different forms, but now we are getting to the very end, so there's going to be a hard deadline really on everything, which will be December 21st, and that will include the CTO arrangement as well as your participation agreement. So keep that in mind, make sure it's on your calendar, and know that everything will need to get completed in order for you to get started in the program this year on January 1st. With that being said, I want to hand it over to Megan at CRISP.
Great, thank you. Hi, everyone. My name is Megan Priolo. I'm the Senior Director of Reporting and Analytics with CRISP. Thanks for having me this evening. Hope you're all nice and warm and someplace dry. Today, our goal is to provide a high-level overview, just a little preview of the reporting tools that are under development and that will be made available to support MDPCP practices. We always like to start with our presentations with our mission, vision, values, and goals. Our vision to advance health and wellness by deploying health information technology solutions adopted through cooperation and collaboration. The key words there are collaboration and cooperation. I think we're definitely doing that here. In the interest of time, I'd like to skip ahead to the rest of the content. So next slide, please. Great. So there are multiple ways in which CRISP has committed to supporting MDPCP. Tonight, we're focusing on the second item of the claims-based reports, but CRISP is also working to enable additional HIE tools to facilitate better care coordination, and will also aggregate quality measure submissions from the participating practices. Next slide. So CRISP has partnered with H-Metrics, and H-Metrics is developing reports based on the Medicare claims data. These will help practices better understand things like emergency department visit rates for your practice, hospital admission rates, and specialty referral patterns. Attribution files from CMS will be used to link the data to practice locations and CTOs where applicable. Next slide. Next, I'll walk through some of the early wireframes of the reports that are under development. This wireframe is a summary page that includes key metrics such as beneficiary count, claim count, average risk tier, inpatient admissions, per member per month, readmission rates, and ED utilization rates. These are broken down by age, gender, and by claim type in the visuals below. The idea is for many of these items to include drill downs so that practices, care managers, providers can work together to be able to get more of the detail behind each of these high-level metrics at a patient level. Next slide. So this view displays sorry, did I go back too far? Yep, that one. Number 10. Perfect. So this view displays comparisons from the base year to the current year for several key metrics and by claim type. So things like beneficiary count, beneficiary month, PMPM, inpatient and ED utilizations. Again, looking at those for the base year, the current year, and the percent difference. Below, there's visual indicators for the percent differences from the base year as well, broken down by the claim types on the screen. Next slide. We plan to also make available some benchmarking for MDPCP participants for things like risk tier, age group, HCC score, dual status, gender, and race and ethnicity. Next slide. We are also looking to display per member per month data with the ability to break this down by claim type in the ER, home health, hospice, and other categories you can see on the screen on the upper left side. Also looking at this by Part A and Part B and total. We also plan to have this available to be able to be trended over time. So you can see below there's trends for the various quarters, both at the practice level and at the state level. I should also mention the idea along the very top, I did not mention, there are drop downs. So you can see where it says tier, CTO, practice, and state, and the date. So those are items that will be kind of like sliders and adjust. You can modify those to look at the appropriate data based on what you're trying to discover. So next slide. Okay. So we are looking to also make available some drill downs, as I mentioned. This view shows what it would look like to have drill down by the provider specialty. So on the left side, we've selected ophthalmology. If you highlight that, you can see the beneficiary count, the claim payment amount, and the average claim payment amount by practice. Once you've got that one highlighted to the right, that data will also update for the data within that specialty. So that'll include things like the provider's name, the provider specialty, the beneficiary count, and this also claim payment amount and the average claim payment amount. So again, as much as we can, our goal is to try to make things drillable so that you can have the data be the most actionable for the practice. Okay, next slide. This slide is a wireframe that shows some visual representations of beneficiary distribution by payment bands. So for example, in this slide, you can see the majority of the patients are falling in that $1,000 to $10,000 claim band on the right side. Furthermore, the bubbles, if you click on one of those, that will take you through to the drill throughs of the patient level detail. Next slide. Slide 15 shows some additional visualizations. So these display the total payments for the various diagnoses within the CCS. So, for example, on the left side, you can see that diseases of the circulatory system are a very significant expenditure for this particular group. And on the right side, we can include information on the percent of the population that has a given condition. The idea is to also, the red numbers there would be to be able to bring in some benchmarking data to see where we stand compared to other MDPCP practices and the rest of the state. Next slide. Okay, so this is a early wireframe of utilization. So we're looking here at inpatient utilization rates, readmission rates, and emergency room utilization rates. So we have that as a high level in the table. We're also looking to be able to view that trended over time. And we also, again, want to have the ability to drill down to the patient level. And so the one on the very bottom, oops, sorry, I'm scrolling on my computer, as you can see the beneficiary count. So the majority of the patients look like they have 0 inpatient admissions in that bottom left graph there, with fewer patients having more significant utilization. Okay, next slide. Great. Okay, so we will also display information around professional services. In the table along the top, we display information such as beneficiary count, claim count, and claims for professional services. Also in this wireframe are views of the top 20 specialties, the places of service, and the providers. Again, along the top, we've got those abilities to filter and modify date ranges and populations as appropriate. Next slide. Okay, so again, we want to do as much of the ability to drill down, take that high level metric so that you can understand directionally where things are looking for your practice or for your CTO, but to be able to drill down to the level where you can get a list that could be handed to a care manager or to a provider to kind of work through and decide appropriate care plans and courses of action. So this is a view that demonstrates that drill through ability. So again, we've clicked on a specialty. That then on the left, that will populate the tables on the right to see the top places of services and the top providers. And I'm going through this a little quicker than I anticipated, but the last couple of slides are to display what we are looking to be able to provide for the reports for the patient details. This is a list of patients that would be attributed to a particular physician. So you can see some demographic information for that patient, along with some of the information from the claims data, such as the HCC score, the total number of claims, and the claim payment amount. So again, this is a list of individual physician or patients, excuse me, for an attributed physician. But if you click on one of those patients, again, we further drill down. So the next slide. This next and last slide shows the beneficiaries. So we've highlighted one, and then you can see the full detail of the claims that have occurred for that particular patient. So you can again see the primary diagnoses, the provider's name, the claim counts, and the claim payment amounts. So we try to get as detailed as we can so that this can be something that could be used as a tool for care management, but also for high-level understanding how we're performing on key metrics. So again, I apologize, I went through this a bit quicker than I anticipated, but happy to take any questions. So I'll turn it back over to the program office.
Great, thank you, Megan. So we're going to go ahead and open up the question box and see what's come in. If you haven't typed your question in already, please go ahead and do so now, and we'll read through them in the order that they came in. So our first question is, we joined late. Could you please repeat the information about what's coming out in the first week of December? Are we waiting to start executing the CTO practice participation agreement until then? So in terms of what's coming out in the first week of December, there's going to be the participation agreement with CMS, and CTOs sign one with CMS, and practices sign their own participation agreements with CMS. For any practices that are partnering with a CTO, there will be what we're calling the CTO arrangement. And that document is with the CTOs now, and they are not going to share it until they get a final list of partner practices from CMS. So you'll only be seeing that document if you've partnered with a CTO and if you pass sort of round 2 of CMS vetting. There's also going to be information in early December about 2 portals to sign up for, but that'll just be kind of a registration process and not full portal access just yet. Our next question is, can practices view the CTO arrangement? Or, the CTO participation agreement?
The CTO participation agreement is a CMS document, and they haven't made those public yet. I think they will, when they make them public, they're going to make them available to the applicable party. So the CTOs will receive a CTO PA, and the practices will receive a practice PA.
Thank you. Our next question is, when would we be notified if a practice doesn't complete their agreement, and is there latitude for lateness in submitting their applications due to the time of the year? So unfortunately, no. All those deadlines are hard deadlines because everything needs to be signed and in place and fully executed before the program starts on January 1st. So CMS is going to be sticking to that final deadline of Friday, December 21st. And we have a question here for CRISP. Can you elaborate on what wireframe means?
Oh, sorry about that. Yeah, it basically is just a screenshot of what it looks like currently. So we haven't actually, these are not functioning reports. So if you're currently a user of the CRISP reporting services portal, you're accustomed to logging in and seeing Tableau reports that are very dynamic, and they're up and running, so to speak. So the wireframe is essentially, this is the plan of how it will look.
Okay, great, thank you. Next question is, your emphasis on PMPM in reporting is interesting. Is there going to be an upcoming emphasis in managing total cost of care similar to other risk programs?
So I'll jump in here, and then anyone else from CRISP or the rest of the team wants to add. But the reason we have the PMPM is to give the practices a view into the claims of their attributed beneficiaries, and that's often the easiest way to look at it and understand across sectors and what that looks like. As you know, the practices are going to be measured on ED and hospital utilization. Those are the measures that are most closely and directly related to total cost of care. Also, as you know, the practices aren't, that is how they're being held responsible for total cost of care.
Great, thank you. Next question, when may we expect the beneficiary high-risk category details? So those will probably be not available until January, even though CMS is running attribution now. Everything won't be final until the program actually starts. So when you log into the MDPCP portal beginning in January, all your beneficiary risk details will be in there. Question here for CRISP. Will the specialist data allow us to differentiate low versus high cost specialists? Average claim payment at the patient level may not correlate to their overall cost rating.
That is a good question. I'm trying to look through. Audrey, if you know this off the top of your head, great. If not, I may need to take it back and discuss it with you.
I would just say, at general, we have the average claim payment at the specialty level and at the provider level. So you would be able to have some indication of overall high versus low cost at a specialty and at a provider. But we understand your point and we'll certainly look into that further.
I'll just add, the real purpose of the specialist data is to show you where your beneficiaries are going in terms of specialties, and to highlight specialists that are treating your beneficiaries that are either high cost or have significant number of utilization. Purposes of care coordination. This is not going to be a red, yellow, green highlighting of cost of the specialist.
Next question is about when we were discussing looking to be able to provide, what does that translate into hard dates?
If we're, I guess, is the question, if you could type in a follow-up question to that, is it specifically around the reports, access to them and the data, or more any CMS related documents?
And while we're waiting for a little more clarification there, question from a CTO. As a CTO, when will we get the revised CTO participation agreement with the MDPCP program? So both the participation agreements for CTOs and for practices are going to come out in that first week of December. And that document will be final. It'll come out from CMS, and you'll need to sign that as is. Next question is, will we have access to claim level data, and if so, through what mechanism?
So in respect to CRISP and the CRISP reports, they are dynamic and they are drilled down from the CTO to practice to provider to patient level, beneficiary level. If you're talking about specific CCLF data or a direct download of claims data or claims files, that would be requested to CMS.
Next question is, where can I find these reports?
So these reports will be available when the program starts in January, and we will, in partnership with CRISP, release end user training documents on where to locate those, how to log in and access them, any additional user provisioning that needs to be done as well.
Great, thank you. Next question, will we get a preview of the risk stratification tool that will be made available in CRISP during the first performance year?
I believe when the tool is ready and when it has been developed, we will be able to release that, similar to what we're doing now via webinars. We may have a key group of stakeholders to kind of do some initial review, but that won't be until, you know, the end of calendar year 2019 sometime.
Thank you. How will MIPS be reported in 2019?
For questions related to macro, we can't comment on that. That's the question to CMS in terms of your macro reporting.
In one of the CRISP reports, it mentions specialty care utilization. What percentage of specialty care providers in Maryland report to CRISP?
So I believe the specialty care providers that you're going to see on these reports from MDPCP are coming from the claims data from CMS.
That is correct. All the reports that we've displayed tonight, the source for that data is the Medicare claims data. So if a specialist has submitted a claim on that beneficiary to Medicare and it's been paid, it will be included in that data set and reflected in the report.
Will there be any opportunity to change the beneficiary's risk score based on factors like social determinants of health, such as medical literacy, transportation issues, etc., that the practice identifies?
It's a great question. Certainly that's a component and a factor that you would probably want to use for doing your risk stratification and determining your care management. As of now, the risk scores are based on HCCs from CMS. It would have to be explored for the future to include social determinants in terms of adjusting those risk scores.
Next question is, when is the platform or dashboard live? Who has access? How can we get access and training on how to use?
So we'll be releasing specific details about this as we get closer to program go live in the beginning of January. In partnership with CRISP, we'll release training documents, we'll utilize coaches, we'll ensure CTOs are up to speed, and that any user access requests that need to be filled out or completed are going to be communicated and sent out, and we'll work with you to get that access.
Great, thank you. Is this data and associated reports simply based on claims data or clinical data as well?
So the reports that we've displayed tonight are based off of the claims data.
Thank you. Can you speak to what a practice will see versus a CTO? Will CTOs have a summary version of all the practices attributed beneficiaries?
So I think it will be based on what they are privileged to see, but that CTOs should be able to have access to, I guess I would defer to the program office a bit on what they should be able to have access, but technically a CTO can have access to the practices, the reports for the practices within their CTO in the subsequent reports.
Correct, and those would be drill down. So again, as long as there's a BAA in place between the practice and CTO, with the practice giving the CTO access to their data, the CTO can then log in via CRISP and view those drill down reports. So starting with a high level aggregate based on their specific practices, and then drilling down to the practice level and provider level and beneficiary level.
Like our next question is coming from a CTO. So we have 25 CTO partnering practices. Do we need to have Appendix A initialed by all 25 practices? So as a CTO, once CMS sends you the final list of practices that have been partnered with you, you should send a separate document to each one of those practices. And each practice is going to initial next to the services that they want. So if you have 25 practices, there will actually be 25 agreements that you as a CTO need to manage. As a practice, you just have one document between you and your CTO. Question is back to CRISP. Is it simple to get these reports from CRISP? Does the CTO only need to tell CRISP what practices we are working with, and then they simply send the CTO monthly reports?
So access will be pretty straightforward. We will be provisioning users, again, based on a BAA agreement between the CTO and practice. Once that is in place, a CTO can request access, and you will have a user account to go ahead and log in, access the MDPCP reports dashboard, and then be able to see your practice reports.
Great, thank you. Next question is, when do CTOs know the final qualified practices they are working with? So that list will be coming out in the first week of December. CMS will be sending each CTO a letter that lists each one of the practices they're partnered with. That'll also tell you what track those practices are in and what CMS payment option they've chosen. So keep an eye out for that early December. Next question is, how can I obtain CRISP access?
So we will have a user request process put in place once the dashboard is ready to go. There'll be a point of contact at each practice location and each CTO, and then that point of contact will help any other practice users who need access to the reports or should have access to the reports, and we'll get them user accounts and logged in. And again, there'll be training provided, etc. And of course, all of that is, again, contingent upon having documents completed, such as the participation agreement with CRISP.
Thank you. Question on when exactly will the CRISP wireframe items be ready?
So wireframe really is kind of your test mock-up, if you will. So the dashboard itself with the reports being live will be when the program starts in January.
Does the CTO log into CRISP to get the reports, or are they sent to the CTO?
So the CTOs will log into the MDPCP CRISP reporting dashboard to obtain these dynamic drill down reports.
We are a single TIN medical group with 39 discrete provider locations. A central home office supports all of them. Can we access information for all 39 through one portal or access tool?
When we go through the user provisioning process and we've identified the point of contact for getting CRISP access for those practices, you would then be able to log in and see all of the practices within that TIN.
Question here. Will CTOs have the ability to receive the raw data, assuming CCLF, that are populating these reports?
So CTOs and practices can certainly contact CMS to request any CCLF direct interface feeds. Any direct interface feeds will not be provided via CRISP.
Thank you. Similar question to one we've had before. When will the CRISP reports be available, and also what is the lag time of the data?
So the reports will be available when the program starts in January. As far as lag time goes, I would actually defer that to Megan.
Sure. So the lag time is typically around 2 to 3 months, just for claims run out and processing.
Great, thank you. Our next question is, Can you please expand on what the staff types mean in Appendix A?
So in Appendix A, the CTO will identify the services that it would provide to the practice that support a particular care transformation requirement, for example, 24/7 access. At the same time, they'll identify what types of resources that, not necessarily the number or the exact name of that person, but the types of resources they're planning on deploying to the practice to support that, whether it's a community health worker or a nurse care manager, et cetera.
Thank you. How often does the risk score get updated?
So I believe it's done annually, and I can just double check on that, but I believe it's an annual update.
Thank you. How are ECQM data supported to CMS?
I believe that should probably read reported to CMS. During the first program year of 2019, we're going to be establishing a process for that. I will say the existing process for some practices currently is to use one of the CRISP tools, Caliper, to report those or to have those reported from their EMRs. We're going to be working on a manual reporting process as well, so that there's a tool available to practices who want to use it so that they can submit their ECQM data and have that sent to CMS.
And just to add on to that, as I think was noted in the RFA, the data, the quality data will be submitted to CRISP, and then CRISP will compile all of it and send it to CMS.
Thank you. Does the high and low cost for specialists indicate quality of care for the specialists too?
No, so this is not a high and low cost tool. This is identifying who are either the high cost specialists or high utilization specialists who are serving your beneficiaries for purposes of collaborative care, care coordination, et cetera.
Another timeline question here. When will the practices have access to CRISP with these reports and the attribution data from CMS?
So again, any of the CRISP reports or program data from CMS will be available when the program starts sometime in January.
Duplicate questions here that I think we've already answered, so I'm skipping over those. Question for Chris. Is there a separate registration for CRS?
So CRS is CRISP reporting services. So that will relate to what Rachel was outlining in terms of the credentialing process that'll be outlined when the reports are ready for go live.
Megan, can you just say, Megan, can you add just for a minute here to explain that what you've shown here are claims-based reports that are going to be made available, but there will be other CRISP tools that many of which are already in place that would be part of essentially like an MDPCP suite. Is there going to be, other than having a participation agreement with CRISP in order to access those tools, is there anything you want to highlight of where there would be separate credentialing for a particular CRISP service?
That is a good question. So I think if there are desires for reports outside of these, we could follow the same process, though, to have a point of contact at each individual organization that can identify individuals that can have access to reports. I think beyond that, if we wanted to look at things like setting up an ENS panel, we could work with the CRISP support team to do that. I think to answer your question, I'll circle back with Craig to see if we have anything that can be a document that we can share with the group to better outline that for you.
Thank you, Megan.
Come on.
question, can you confirm that the CRISP reports are available to all practices, not just the CTOs?
Yes, CRISP reports are available to all practices and CTOs only if they have a BAA agreement with the practices that they're serving.
Thank you. With a delay in receiving the participation list for the practices, when can they expect their first CMS payment?
So I believe the first payment that are going to come out from CMS are going to be in the end of January.
Will CRISP update discharge status for deceased patients? Right now, we don't know if the patient has died.
For any questions such as these, I would recommend that you please direct them directly to CRISP via their email or website, however you would provide, typical questions or feedback to.
So for any questions about requesting claims data, we recommend that you submit those to the CMS inbox.
I think we've had a similar question before, but what is the claim lag time between submission and showing up in CRISP reports?
I believe that is 2 to 3 months.
Correct.
Great, thank you. Will practices have access to all of these reports, and who will train them in how to interpret and act upon the data?
Practice will have access to all of these reports. In terms of getting trained on them, we'll make some user manuals available. You will also have access to coaches provided by the state. And in addition, if you're working with a CTO, they're likely to help you as well.
Can you explain how we would be expected to perform stratification without access to the CCLF data?
So stratification, as you probably know, can be done a variety of different ways. Once you get the HCC scores of your attributed beneficiaries, that's one way of initially stratifying. You certainly can stratify using data that you have in your EHR, there's otherwise you could put in place an algorithm that makes sense for you in terms of stratification, but that can be done by clinical or claims data.
Just to reiterate again regarding claims data, so the CRISP dashboards and reports are going to display data as we were showing, aggregate data, dynamic data, drill down data for practices and, again, CTOs who have a BAA with their respective practices. Only practices could request CCLF data from CMS. CTOs can get the data via their partner practices through a BAA.
Great, thank you. If the CTO only offered half of the services in Appendix A, how would that affect what practice they were mapped to? Is there a minimum number of services that must be offered in Appendix A, or does CMS recommend that the CTO offer each service in Appendix A?
Per the RFA and the participation agreement, the CTO is responsible for assisting the practice on all care transformation requirements. For either option 1 or option 2 of the care management split, the CTO is expected to be supporting the practice on all requirements. So we won't make a recommendation here, but it would be the expectation that the CTO provides some kind of support for all of the requirements.
Great, thank you. How can we find out if our EMR is equipped or set up to send ECQM data to CRISP?
So if you currently don't have an interface or connection with your EMR to the CRISP tool caliper or are currently submitting, we will have a process in place in calendar year 2019 for your ECQM submissions, and we will help to establish your EMR version if there's any upgrades needed. You can also find that out on the ONC website. And then once the tool is established and the process is established, we'll provide training on how to do so.
Great, thank you. Do we receive a preliminary or prospective patient attribution list ahead of January?
No, unfortunately, the attribution and the assignment of all the beneficiaries will not be shared until the beginning of the program starting in January.
Could you please expand on Appendix B?
So Appendix B for the CTO arrangement is going to outline. Let me just. Why don't we just go back to it real quick so we can all see it. So Appendix B is where you are to, as part of the agreement, you need to have a business associate agreement added in there, and that could be either one that the CTO uses or it could be one that the practice uses, and it needs to call out that the practice is the covered entity and the CTO is the business associate. This needs to be in place in order for the practice to share its clinical and/or claims data with the CTO.
Will trainings be offered to CTOs for CRISP, or should we use the CRISP helpline?
So I think we're still working through exactly what kind of training materials and training is going to be available, and we'll circle back with you on that.
Should the CTO expect the PBIP payment in January based on attributed lives assigned to that CTO?
Yes, so PBIP is paid at the beginning of the year one time, and that will be done. That will be done via the payment that comes out in January. We're having a little technical difficulty. Just wait. Hang on with us for a second. We're back up and running. Thanks for your patience.
All right. Our next question is, can we get all payer data from CRS?
So these reports are specific to the Medicare claims files. There are additional reports available in CRS based on a myriad of data sources, including CaseMix. But again, the ones we've highlighted tonight are for Medicare only.
So if you have questions about other CRISP services beyond the reports that are being built for MDPCP, we recommend reaching out to CRISP. Megan, what's the best way for them to contact you?
Probably the easiest way is support@crisp.health.org. But again, or if folks would like to contact me directly, that's fine too. My email address is megan.priolo@crisp.health.org. megan.priolo@crisphealth.org.
Thank you.
Great. As a CTO, do we receive Appendix B from the MDPCP program?
No, so we would that the BAA is going to be something that you're going to provide, or the practice can provide as part of the overall document.
Are there any actions that practices need to take before January in regards to CG CAP?
No, I don't believe there's anything that you need to do on CG CAPs prior to January.
Great. An administrative question here. How can we get a copy of these slides and slides from prior presentations? So we will be sending out the slides from this presentation later this evening, and a recording of the session will be posted on our website probably next week. If you want to take a look back at any of the other sessions that we've done over the past couple of months, both the slides and the recordings are on our website. The website link's posted here, health.maryland.gov/MDPCP. And on the left-hand side navigation, there's a section for practice information. And if you scroll down, there is a heading under education sessions. And everything that we've done over the last several months is posted there. And that was actually the last question that we have for now. If there's anything else that you were thinking of, please go ahead and type it in now.
Otherwise, feel free to reach out via the email inbox that's on the slide that you're looking at now, or going to the website as well. We appreciate your time today on a snowy, wet, icy day, and wish you a nice evening and a safe evening. Any last questions? Looks like that's it. Now, Alice, do we have any upcoming webinars?
Yes. So we're going to continue this Thursday series, but next Thursday is Thanksgiving, so we will be skipping that. But the following week, we have a session scheduled on social determinants of health, and then we have one or two more scheduled in December. One of them will give you a preview of the CMS learning system and all the other great things that you can expect come January. When we send out the slides from the session, we will also be sending links to all of those other webinar sessions from now to the end of the year, so you can sign up for those later today. Also just want to give everyone a quick heads up. If you've been following our newsletter, we generally put that out every 2 weeks. We will be transitioning that as well. Once everything launches January 1st, we're going to shift to a slightly different branded newsletter, working a little more closely with CMS on some of the technical program content that'll be coming out. So expect to see our webinars and our newsletter throughout the end of the year, and then things will transition and look a little bit different come January.
Great. Well, thank you all for jumping on. Really great questions. We always appreciate the opportunity to hear from you. And in the meantime, happy Thanksgiving to all, and we'll talk to you soon.